The stomach operates as a strictly organized geographic map. The specific location of its blood vessels and specialized cells entirely dictates how its diseases manifest and how surgeons must operate to fix them. This diagram shows the stomach's blood supply, with arterial arcades tracking along both the lesser and greater curves. Notice the gastroduodenal artery, or GDA. It descends directly posterior to the first part of the duodenum, placing it directly in the path of penetrating ulcers. Along the bottom edge, right and left gastroepiploic arteries form an arcade along the greater curve. This vascular loop is vital for maintaining blood flow when a surgeon must mobilize the stomach upwards to create a conduit during an esophageal resection. This histological view of the gastric crypts reveals a strict microscopic separation of labor. Acid-producing parietal cells dominate the body of the stomach, while hormone-producing G cells are isolated far below in the gastric antrum. In the body, the parietal cells utilize a hydrogen-potassium ATPase proton pump to manufacture hydrochloric acid. They force hydrogen ions into the gastric lumen against an immense concentration gradient of 1 million to 1. This physical distance between acid production in the upper stomach and endocrine control in the lower stomach relies on a tightly regulated chemical feedback loop. But when a microscopic disease process finds a way to exploit that physical gap, the entire system collapses. This photograph captures the primary disruptor of that anatomical balance, Helicobacter pylori. These dark bacterial clusters colonize the gastric epithelium, weaponizing the stomach's own biochemistry. The bacteria hydrolyze urea into an expanding, protective ammonia cloud. This localized alkaline environment tricks antral G cells into detecting a false state of low acidity. They release excess gastrin, which travels upward to hyperactivate the parietal proton pumps, flooding the stomach with unneeded acid. That excess acid inevitably spills downstream. The duodenum adapts by undergoing gastric metaplasia, a process where normal intestinal lining converts into stomach-like tissue. H. pylori bacteria then migrate and colonize this tissue, directly eroding it into duodenal ulcers. Surgeons used to permanently alter the stomach's anatomy to stop this hypersecretion. Today, patients simply take a combination of proton pump inhibitors and antibiotics. Dismantling the microscopic feedback loop entirely removes the need for the scalpel. Elective acid-reducing operations have been obsolete for decades. Modern ulcer surgery operates strictly as a damage control response for acute, life-threatening mechanical failures. The most immediate threat is a massive upper gastrointestinal hemorrhage. Clinicians stratify the severity of these bleeds using the Rockall score, a clinical system that factors in a patient's age, state of shock, and comorbidities to predict the exact risk of rebleeding and death. This cross-sectional diagram illustrates the anatomy of a catastrophic bleed. A posterior duodenal ulcer deepens until it erodes completely through the duodenal wall, directly breaching the adjacent gastroduodenal artery. Frail, elderly patients in hemorrhagic shock lack the physiological reserves to survive prolonged hypotension. Counterintuitively, their fragility dictates that they require earlier surgical intervention than younger, healthier patients. Looking at this surgical illustration, we see the required operative maneuver. The surgeon fully mobilizes the duodenum and makes a longitudinal incision to expose the inner lumen. They locate the breached vessel at the base of the ulcer and tightly underrun it with a suture to arrest the bleeding. If the surgeon closes that longitudinal cut linearly, the pyloric channel will scar and narrow. Following the Heinecke-McCulloch's principle, the incision is pulled open and sutured transversely, ensuring the outlet remains wide. The operation does nothing to cure the underlying ulcer disease. It only mechanically secures the artery, keeping the patient alive long enough for pharmacological therapies to permanently heal the tissue. The second major mechanical failure is a full-thickness perforation. The ulcer burns a hole completely through the gastric or duodenal wall, spilling acidic contents and food debris directly into the sterile peritoneal cavity. Classic textbook symptoms, like sudden, board-like abdominal rigidity, are often entirely absent. Many perforations occur in elderly women taking NSAIDs or corticosteroids. These drugs severely blunt the physiological inflammatory response, masking the catastrophic leak inside. Because clinical signs are unreliable, the diagnostic gold standard relies on imaging. Clinicians look for pneumoperitoneum, free air inside the abdominal cavity that rises to collect underneath the diaphragm, clearly visible on an erect chest X-ray or CT scan. The immediate surgical mandate requires a thorough peritoneal toilet to wash out the toxic debris. The surgeon then seals the hole, typically reinforcing the closure with a Graham patch, a technique where a well-vascularized piece of omentum is sutured over the defect to plug the leak. Duodenal perforations are almost universally benign, but a perforated gastric ulcer carries a high statistical risk of underlying malignancy. The surgeon must explicitly biopsy or fully excise the edges of a gastric perforation for histological screening. Treating a perforation forces the surgeon to execute two separate mandates at once, establishing mechanical infection control to fight sepsis, while acting as an oncologist to catch hidden cancer. The final emergency in the triad is gastric outlet obstruction, or GOO. Repeated cycles of ulceration and healing create dense scar tissue that completely blocks the pylorus. Patients present vomiting large volumes of undigested, non-bilious food. This flowchart maps out the resulting biochemical crisis. The continuous vomiting expels massive amounts of hydrochloric acid. Blood chloride levels drop, driving the systemic blood pH upward into a profound state of hypochloremic alkalosis. Because the patient cannot keep fluids down, severe dehydration sets in. To preserve the failing intravascular volume, the kidneys aggressively reabsorb sodium from the urinary filtrate back into the bloodstream. The kidney cannot retain positive sodium ions without giving something up in exchange. To keep the sodium, the renal tubules are forced to expel potassium and hydrogen ions outward into the urine. This ion exchange results in the hallmark presentation of end-stage goo, hypokalemia, or low blood potassium, occurring alongside paradoxical aciduria. The patient's blood is dangerously alkaline, yet they produce highly acidic urine as their kidneys sacrifice pH balance to maintain fluid volume. Subjecting this patient to an immediate surgical drainage procedure like a gastroenterostomy is lethal. The clinical rule dictates that they must first undergo aggressive metabolic resuscitation, utilizing intravenous isotonic saline and potassium to correct the ion deficits. The mechanical blockage prevents the patient from eating, but the resulting cascade of severe ion depletion will trigger a fatal arrhythmia long before malnutrition takes effect. When the pathology shifts from benign ulcers to malignant disease, pharmacological management reaches its limit. Decidative anatomical resection remains the absolute standard for a cure. Pathologists use the Lauren classification to categorize the disease. The intestinal type frequently arises from regions of H. pylori-induced metaplasia. By contrast, the diffuse type infiltrates deeply into the gastric wall without forming a distinct mass and carries a significantly worse prognosis. This diagram highlights a strict boundary within the UICC-TNM staging system. If a tumor's epicenter is located within a 5-centimeter zone around the gastroesophageal junction and extends upward, it is staged and treated as an esophageal cancer, not a gastric one. Curative surgery demands an R0 resection, securing microscopically clear margins with absolutely no residual tumor left behind. This must be paired with the en-bloc removal of specific regional lymphatic basins. The optimal extent of lymphatic clearance dictates the surgical approach. A D1 lymphadenectomy removes only the perigastric nodes immediately touching the stomach. A radical D2 dissection requires a much deeper, more complex operation to strip the lymph nodes surrounding the principal arterial trunks of the celiac axis. Gastrointestinal stromal tumors, or GISTs, bypass this rule entirely. These are mesenchymal tumors driven by a mutation in the c-KIT oncogene. They rarely spread through the lymphatics, rendering wide node dissections useless, and they shrink dramatically when targeted with tyrosine kinase inhibitors like imatinib. In gastric oncology, the scalpel only cures when it is guided by precise pathological classification and uncompromising anatomical clearance. Removing or permanently bypassing the stomach's reservoir capacity to eradicate these diseases guarantees a lifetime of physiological consequences. The left panel demonstrates early dumping syndrome. Without the stomach to meter digestion, a high osmotic load of food rapidly enters the duodenum. This aggressively pulls water from the surrounding vasculature into the lumen, causing a sudden drop in blood pressure and severe colic. The right panel illustrates late dumping syndrome. When a rapid carbohydrate load hits the small bowel, plasma glucose spikes rapidly. The pancreas overcompensates with a massive insulin release, eventually plunging the patient's blood sugar down into a severe hypoglycemic crash hours after eating. This surgical diagram details a Roux-en-Y reconstruction. Altered anatomy from simpler resections frequently causes intractable bile vomiting as duodenal fluids wash backward into the gastric remnant. A Roux-en-Y configuration is often utilized as a surgical salvage to permanently divert biliary and pancreatic secretions downstream. Patients must also manage inevitable nutritional deficits. Surgical loss of parietal cells removes intrinsic factor, a glycoprotein essential for absorbing vitamin B12, mandating lifelong injections. The drastic reduction in gastric acid also impairs the absorption of iron and calcium, leading directly to chronic anemia and metabolic bone disease. Those who underwent historical acid-reducing operations face a delayed, critical threat. Decades of chronic bile reflux washing into the altered gastric remnant drives intestinal metaplasia, establishing the prior surgery itself as an independent risk factor for developing future gastric cancer. The stomach is a highly calibrated biochemical engine. Altering its baseline topography to solve a localized anatomical problem exacts a permanent, systemic toll on the patient.